Okay, good evening, everybody. Today we have a speaker from the Sunway Medical Center, who is Dr. Hugh, who's a consultant neurologist. He's going to speak to us about Gullain-Barre syndrome. And the next few talks, actually, I've purposely chosen topics that could be related to side effects of vaccination, especially an increased risk of autoimmune disease. So without further ado, Hugh, Hugh, go ahead.
Okay, thanks, Betty. Thanks for, first of all, I would like to thank Betty and also Beating Heart for inviting me to speak on Guillain-Barré syndrome. In short, we call it GBS. And also, of course, with collaboration with Sunway Medical Centers, Sunway City. For those that do not know me, I'm Dr. Hugh. I'm the neurologist from Sunway Medical Center. Yeah, I don't really have much disclosure per se, but just trying to move my slide, but it doesn't seem to be moving. Okay, so this is the outline of my talk. I'm going to just briefly talk to you with regards to introduction to GBS, where it's mainly more to historical aspect. And I will speak on something that related to GBS, which is the preceding event, and also its pathogenesis, which is very closely linked together. And how to diagnose GBS, how do we assess and also monitoring patients with GBS upon admissions, and how do we treat them. And of course, I'm going to touch a little bit on the outcomes, some newer therapy which is in the pipelines, and also I would just, at the end, just wrap up with just a short conclusion. Okay, of course, I put up this slide. It just, we are now probably going into World War III, which I hope not. But during the World War I, that was back in 1916, on the 1st of July, there was actually a bloodiest battle between the French and the British Army versus the German in a place in France called the Somme River. Apologize if I pronounce the name of the river wrongly because it is in French. Of course, this is despite me watching Emily in Paris. It doesn't really.
If you watch Emily in Paris, I love that show.
Yeah. But the thing is, it seems that I don't have really much.
Don't worry, Emily cannot speak French either.
Yeah. So back then, during the World War I, this war itself actually has killed probably more than 1 million men. And half of them from the British and the French troops, and the other side, the German. But at the end, the German withdrew, and same as any other war, we don't really know who won at the end, and it is still inconclusive until now. So this is how it looks like back then. You can see the soldiers, they can see the number of warheads that was being left behind, and also that time you are talking about horses, carriage and things like that. But nowadays, I don't think you will see this kind of warhead anymore because you probably just need one atomic bomb to just destroy everything, and you don't see the warhead and nothing left.
Was it this the end of this war was the start of the massive influenza?
Not really, not yet.
Really? Not yet. Okay.
Yes. So back then, a month after the war started, there was these 2 soldiers that was admitted to the French 6th Army camp with progressive weakness in the limbs. So at the time, they saw 3 physicians, which was treated by these 3 physicians. The first one is actually, again, my French, apologize, Georges Gullain. At the time, he was the head of service of, and he was a neurologist. So he examined the patient, and he said that look, this is something peculiar. And at the same time, the same patient was also seen by John Alexandra Barr at the time, who was actually a neurologist. And the test itself, including the lumbar puncture, the neuromuscular testing, and also the nerve conduction test, was actually done by this guy called Andrea Stroll, which was at the time doing a degree in physics. So these 3 guys was, in charge of treating these 3 patients. That's why the name GBS, right? So Guillain-Barré syndrome. So why straw was actually dropped from the name? It was very political to mention, but it was actually quite interesting. You can find out why. So at the time, these three physicians actually noted that the patient has got a weakness in the lower limb and subsequently involving the upper limb as well. That's why they call it at the time ascending paralysis. There were tendon air reflexia, but however, the cutaneous reflexes was all preserved. Sensory involvement was very light. It wasn't very severe. It was actually noted to have a very remarkable increase in the albumin on CSF, despite no increase in cells. So this is something new at the time, because normally when you have meningitis or encephalitis or any form of infection in the brain, you do see high protein and increased number of cells. But in this case, only high protein, but there was no cells. So they call it albuminous cytological dissociations. And somehow these two French army just resolved and have a very good prognosis at the end. So at that time, the muscle reflexes was done electrophysiologically by straw, and it was recorded that there was absence of tendon reflexes, and also the nerve test actually shows that there was prolonged latency, which is meaning that there was actually evidence of slowing of conduction along the nerve. So now we call it demyelination. So they insisted that, look, this is something which is very new. So they published this paper in Paris at the time, and something which they call it inflammatory disease of the peripheral nerve without, reflexes, but with a very high protein on the CSF, which we now call them Guillain-Barré syndrome. So until now, Guillain-Barré syndrome, or GBS, is an inflammatory disease of the peripheral nerve, and is the most common cause of acute paralysis worldwide. It is being estimated the incidence is around 1 to 2 per 100,000 person years, but seen more common among males, and also the incidence actually increases with age. So it is actually a post-infection autoimmune disorder of the peripheral nerve and also the nerve root. Yeah, characterized by what we call infiltrations of the nerve with leukocyte, and at the end of the day leading to demyelination and also axonal loss. But somehow this Guillain-Barré syndrome is strongly related to antecedent infection, meaning that they have 60 to 70% of them do have some form of infection prior to the onset of the disease. So that can, go back probably about 6 weeks prior to that. And the most common infections being recorded so far are Campylobacter jejuni, which result in diarrhea, and also CMV, hepatitis E, mycoplasma pneumonia, EBV, and also, more recently in 2016, the reported of Zika virus that caused Guillain-Barré syndrome, among the Polynesia countries. So, but not all patients with this kind of infection are going to develop GBS. Not to say that, okay, you got Campylobacter jejuni, you're going to get GBS. No. So only 1 in 1,000 patients with Campylobacter jejuni infection actually develop GBS. So it's just quite rare. And also, GBS is also noted to be associated with some triggers. The most common one is actually vaccine, for example, the influenza, malignancy, some autoimmune disease such as SLE, surgery, immunosuppressive drugs such as anti-TNF alpha, and also the latest one, immune checkpoint inhibitors. So these are the drugs that can actually trigger Guillain-Barré syndrome. So vaccine actually increases 1 additional GBS cases per 1 million dose of vaccine. This is based on the influenza vaccine. I'm going to talk about a little bit on COVID later on. So this GBS is actually thought to be an immune response kind of disease. So it is actually due to what I call an aberrant immune response to the infection that actually result in the damage in the nerve. So there are mainly 2 types of Guillain-Barré syndrome that we classify them, based on pathology and also based on electrophysiology. So the first one is actually what I call demyelination kind of GBS, and the second is what I call axonal. In the patient with demyelinating kind of types of GBS, is actually due to the formation of autoantibody in the patients that binds to the myelin. Myelin is actually the outer lining of the nerve. Okay, with that the autoantibody is formed against certain antigen on the myelin, and because of that, it activates the complement cascade and result in macrophage infiltration into the nerve and resulting in the damage of the nerve, what we call Guillain-Barré syndrome. So these are demyelinating kind of types of GBS. So for the axonal types of GBS, it is actually due to the formation of anti-ganglioside antibody. So this ganglioside is actually a form of sialic acid containing glycosphingolipids, which is present on the nerve, especially on the nodal and the paranodal area, which is at the node of Ranvier. Because of this kind of formations of antibody which attack the ganglioside on the nodes of Ranvier, it causes the dysfunction of the nodes, and subsequently resulting in the MSC formation, which is the membrane attack formation complex, that result subsequently in the damage of the nerve. So this is strongly related to what we call a carbohydrate mimicry between the ganglioside antigen on the nerve and also the Campylobacter jejuni lipo-oligosaccharides. So in this case, the antibody targeting, so after you got infection with Campylobacter jejuni, what your body does is you'll come up with antibody. So this antibody is supposed to kill off the bacteria, which is the Campylobacter jejuni. But at the same time, the antibody produced by your body actually target, which is supposed to target the lipopolysaccharides of the Campylobacter jejuni wall, cross-react with the ganglioside antibody on the peripheral nerve. And because of that, it actually, kind of like self-destruct the nerve of the patients and result in the formations of inflammations along the nerve and subsequently Guillain-Barré syndrome. So this ganglioside antibody, the most well-established one are anti-GM1 and also the anti-GD1A antibody. It actually binds to the nodes of Ranvier and causes destruction and dysfunction of the sodium channel, and because of that, it results in conduction problems along the nerve. At the end of the day, the loss of function and also the failure of the nerve to conduct electrical impulses. So at the same time, the anti-ganglioside antibody also binds to the motor nerve terminal. They cause the nerve terminal to degenerate and subsequent result in Guillain-Barré syndrome. So the presentation of the Guillain-Barré syndrome mainly, we broadly classify them into two broad classification. So the first one is what we call classical presentation, where typically patients come with acute onset, rapidly progressing, ascending paralysis involving normally the lower limbs and subsequently involves the upper limb, and also some of them do have facial and also bulbar cranial nerve involvement, and at the same time some of them do have ophthalmoplegia and also ataxia. So these classical presentations normally comes with very mild sensory sign, and also at the same time again hypo or areflexia. So some of them do have what we call autonomic dysfunction, dysautonomia, where the autonomic nerve itself is being affected as well, resulting in fluctuation in your blood pressure, your heart rate, and some of them even just involving the pupillary dysfunction, bowel and bladder dysfunction. Pain is a frequent presentation among patients with Guillain-Barré syndrome. It can be muscular pain, radicular pain, or even neuropathic pain. Sometimes can be quite confusing at times, whether this is actually differentiating this, whether it's because of nerve problem or because of muscle problems. So the non-classical presentation of Guillain-Barré syndrome is very diverse. It's very heterogeneous. So, and in fact, they have several distinct kind of clinical variant exist, which can be very confusing, especially for a physician to diagnose. So they have patients that come to you with different pattern of weakness and also sensory sign. But most of the time, although it's bilateral, they can be asymmetrical. They can involve just the proximal, rather than the distal. They can start in the legs, in the arms, or you can just start simultaneously. So a different pattern of presentations. So the classical pattern is ascending, you see, from the lower limb involving the upper limb. But we know that nowadays, more and more patterns, that can happen among patients with Guillain-Barré syndrome. So they come with a different variant. So variant is just a patchy presentation where they do not progress into the full classical pattern. So some of them only have pure motor manifestation. They only have motor dysfunction. Some of them only have facial nerve palsy. Some of them only have pharyngeal, cervical, brachial manifestation. Some of them only have lower limb paraparetic presentation. And of course, the most widely described variant is usually Miller-Fisher syndrome, where they have the full manifestation consists of ophthalmoplegia, areflexia, and also ataxia. And of course, out of these variants, these are patterns. They are also overlap, variant where you can have classical with, bigger stuff, encephalitis, where they develop somnolence, they drop their count, GCS. They appear very difficult to differentiate among patients with encephalitis. They have this kind of overlap patterns can be between different variants of GBS. So sometimes it can be quite confusing to diagnose. You can see from here, these are the most common ones that we see. So the classical one are those that involve, if I can get my pointer. So the classical one are those that involve extending paralysis from the legs, that involve your hand, and subsequently your respiratory muscle and your cranial nerve. These are the classical presentation of a patient with Guillain-Barré syndrome. Some of them can present just the lower limb weakness. Some of them just your pharyngeal muscle, your cervical muscle, and also your brachial muscles, only involving the upper limb. And some of them can involve just your face, bilateral facial paralysis. The Miller syndrome, where you actually have ophthalmoplegia, areflexia, and also ataxia, where you are, imbalanced. This diagram is actually appeared blurred, not because of the screen, but it's just, to illustrate to you, how an ataxic patient looks like. Of course, some of them do have involvement of your, conscious level, where you become somnolent, become sleepy, and which is the bigger stuff, brainstem encephalitis kind of presentation. You need not to have, areflexia to diagnose Guillain-Barré syndrome. Some of them, in fact, have hyperreflexia, where your tendon, deep tendon reflex appear hyperexcitable. And this can be seen up to 10% of the patient with Guillain-Barré syndrome. So this is probably the most important slide for you to learn how to diagnose Guillain-Barré syndrome, because the time course of the disease is something which is very classical. So the patient that comes to you with GBS normally have a median times of presentation from the onset of the infection or diarrhea to the onset of the neurological symptom of around 1 week to about 10 days. So because after the infection, your body need to develop the antibody, so you need time. So it's actually a post-infectious autoimmune disorder. So where your body, after the infection, develop the antibody, and subsequently, when the antibody levels goes up, right? Okay, and it's the start of the disease. And subsequently, you see the antibody levels begins to rise after the infection here, all right? And subsequently, the clinical manifestation, where the disease can actually progress rapidly and become peak, in 1 or 2 weeks, and it reaches the maximum disability within about 2 weeks. And once it reaches the maximum severity, the patient's clinical presentation will become plateau. It will become stabilized, and after about weeks or months, they will start to recover, even without treatment. So this is the natural history of a patient with Guillain-Barré syndrome. So if you see someone that comes to you with, the onset of the disease that reaches maximum within 24 hours, or, it keep on progressing non-stop and deteriorate even after about 4 weeks, that this is unlikely to be Guillain-Barré syndrome, because it does not follow the time course of the disease. Okay, So more recently, we have Zika and also this chikungunya outbreak among Polynesia and also countries also around the Latin American countries. So somehow it's very interesting to see Zika manifestation, because Zika manifestation in the Polynesia and also the Latin America tends to cause Guillain-Barré syndrome, but the Zika manifestation in Southeast Asia or in Asia does not seem to give so much of trouble. And also more peculiar is we do see a lot of Zika infection in our neighboring country, but it just doesn't seem to cross the border to Malaysia. And this is something which is very difficult to explain. But anyway, Zika is actually or chikungunya actually the anthropod-borne viruses that have a medium time to onset of the disease of about 7 days. So you can see that the typical GBS is about 10 days, after 7 days about 10 days, but you can see that the Zika has a much shorter latency between the infection and also the onset of the disease. This is why sometimes we get a little bit confused whether this is actually a post-infectious Zika GBS or what we call a para-infectious Zika GBS. And Zika seems to be the higher incidence of causing GBS than chikungunya, and it tends to have some special features. They have more facial involvement, and also in terms of severity, they are not as severe as those with a typical Guillain-Barré syndrome. And again, the case ratio is about 1 to 1,000 infection that actually develop GBS. Come to diagnosis. Diagnosis of GBS is based on clinical. So clinical history and also neurological examination, supported by, if you have the nerve conduction study, which is your electrophysiological study, and also your cerebral spinal fluid, your lumbar puncture. Sometimes diagnosis can be challenging, as I mentioned before, is because the presentation of the GBS can be very diverse, very heterogeneous. Sometimes we get even confused with patients that come to you with encephalitis, which is not to be a GBS. This is because GBS has got no specific diagnostic tools, and there's no biomarker. There's no such thing that you take a blood and you send it to the lab and it comes back as a result positive and you are GBS. No, it's not like that. It's based on clinical history and also examination. It's purely based on the clinician's judgment, and this is why sometimes diagnosis can be quite challenging. Of course, we do have diagnostic criteria for GBS. Mainly the two widely used are NINDS criteria and also the Brighton's collaborations criteria. The most important thing is we also need to rule out anything that can present similar to GBS. So this is the NINDS criteria, which is the most widely used criteria to diagnose Guillain-Barré syndrome. Again, diagnosis is clinical. If you see someone that comes to you with progressive weakness in both arms and legs, okay, you might want to suspect Guillain-Barré syndrome, especially if someone that comes to you acute or subacute presentation, and if you noted that they are aireflexia. So the supporting criteria for Guillain-Barré syndrome is, as I mentioned just now, in the time course of the disease, the progression of the symptoms over days to 4 weeks. All right. So if the patient still progresses 4 weeks, if there's someone that comes to you, if they've got progressive weakness of the limb, over 2 months or 3 months, that this is unlikely to be a Guillain-Barré syndrome. So relatively symmetrical symptoms, there are mild sensory sign. There is cranial nerve involvement, especially facial and also the bulbar. And patients can have autonomic dysfunction, pain. And if you do a lumbar puncture, if you see high protein with relatively no cells, and of course, if you have got NCS, you do NCS that support either demyelination or axonal form of GBS. And this is how we diagnose Guillain-Barré syndrome. So of course, there are atypical features that you want to say that, look, this is probably not a GBS. So for example, if someone that comes to you with weakness that started yesterday and today developed respiratory muscle weakness and intubated. So this is unlikely to be a GBS because it doesn't follow the typical time course disease. And someone that comes to you with severe sensory sign, okay, but not so much of a weakness. Someone that comes to you with bladder and bowel dysfunction, you think of the spinal cord problem first rather than the peripheral nerve problems. Fever at onset. If fever 1 day, 2 days, and subsequently weakness in the lower limb, is very unlikely to be a GBS because, as I mentioned, it's a post-infectious autoimmune disease. So you need to have the infection first, and subsequently your body generates the antibody, which you need time. It's not you have infection now, tomorrow you develop antibody, and then you develop GBS. It's not like that. It doesn't follow the time course. And if someone have a slow progression, but without a respiratory involvement, but think of something which is more chronic, for example, CIDP, which is a chronic inflammatory demyelinating polyneuropathy. Some patients that comes to you with asymmetrical weakness, of course, asymmetrical can be GBS, you have to be very careful. Persistent bowel and bladder dysfunction. And if you do a lumbar puncture and you see more than 50 cells and predominantly polymorph neutrophil, you have to always think again whether this is actually a Guillain-Barré syndrome. So these are the mimics that you would like to consider in chameleons for GBS and also Miller Fisher. Think of whether virus infections, polio, but hardly see polio nowadays. Traverse myelitis is one of the very often presentation can mimic a Guillain-Barré syndrome, spinal cord injury. Other form of neuromuscular junction disorder, for example, myasthenia gravis, muscle disorder as well. Okay, diagnosis. We routinely send laboratory tests. Not to say that when you send a routine laboratory test, you are going to diagnose GBS. No, it's just for you to exclude other causes of acute facet paralysis, especially hypokalemia. So these are something that you always want to rule out whether this patient has got a hypokalemic periodic paralysis. So testing for infection disease itself, the 6 common viruses and also bacteria that I mentioned earlier. So it's actually not to diagnose GBS, but it's just probably more for epidemiological data. Why is that for epidemiological data? Is because GBS is a post-infectious autoimmune neuropathy. There's no more infection for you to treat. Even if you were to diagnose that this patient has got some form of infection, you don't treat because it's a post-infectious kind of condition. Nowadays, anti-gangroside antibody is widely available if you were to send it to our local labs. And of course, the sensitivity and specificity itself is assay dependent, depending on the methods that they use. But if you have a positive anti-gangroside antibody, it supports your diagnosis of Guillain-Barré syndrome. But the diagnosis is still clinical. You do a lumbar puncture. It's not a must, but if you see, if you can do a lumbar puncture, and if you see an abdominal cytological dissociation, again, this is supportive of the Guillain-Barré syndrome. However, the CSF result is very timing. That is very depends on when you do the CSF. The protein level in the CSF can be normal in up to 50% of the patient if the onset of weakness is within a week. And however, if the onset of weakness is within the second week, it's still about 10 to 30% of them might have a normal CSF protein. So the timing of the lumbar puncture is very important. Okay. If you are in a tertiary center where you have neurophysiological studies, what we call a nerve conduction studies machine, you can actually do a nerve conduction studies and to see whether this is a GBS, of course. And second thing, which type of GBS that they have. The NCS can be quite specific in diagnosing diagnosing GBS because you typically see a pattern of sensory deficit, what we call a pseudo-sparing pattern. Pseudo-sparing pattern is when you do the nerve conduction test, you see a relatively normal pseudo-sensory response. But when you do the median and also the ulnar response in the upper limb, you see that they are relatively absent or reduced. So this is what I call a relatively sparing of the pseudo nerve in the lower limb, but a diminished response of the upper limb sensory responses. This is what called pseudo-sparing pattern. And with that, you can actually roughly know that, look, whether this is a demyelinating form of GBS, which is acute inflammatory demyelinating polyneuropathy, we call it AIDP. If this is an axonal form of GBS, we call it either acute motor or motor sensory axonal neuropathy, AMAN or AMSAN. And of course, some of the patients that don't typically come with either AIDP or AMAN or AMSAN, they do come with what I call a reversible conduction failure, where they don't progress. It's actually probably more to what we call paranodal or nodal neuropathy, where, as I mentioned to you just now, the node of Ranvier, when the antibody actually attack the node of Ranvier, it causes physiological dysfunction of the node. And subsequently, when you treat, they can reverse very fast without causing axonal damages in those patients. We call it reversible conduction failure. Okay, so MI again can be helpful, mainly like to exclude other diseases, for example, a brainstem stroke, encephalitis, and also whether this is a leptomeningeal malignancy, nerve root compression. So if you see a nerve root enhancement on gadolinium injection on MRI, this is again supportive of GBS. So ultrasound is useful at the early stage of the disease. If you see an enlarged cervical nerve root on the ultrasound scan of the peripheral nerve, again, this is supportive of Guillain-Barré syndrome, but only during the early phase of the disease. All right. So once you diagnose the patients to have Guillain-Barré syndrome, you need to start monitoring them because about 20% of the patients with Guillain-Barré syndrome actually will progresses, develop respiratory failure, and some of them might even require mechanical ventilation. This is the greatest concern of a patient with Guillain-Barré syndrome. They might be well in front of you when they first admitted to you, but subsequently they will progresses and they develop complication. So one of the major complications is mechanical ventilation because of respiratory failure. And some of them, they do develop autonomic dysfunction. They develop fluctuation in blood pressure, the heart rate, and because of that, some of them actually succumb because of this autonomic dysfunction, and something which is not easy to manage if they do develop this complication. So those patients, you need to assess them because you need to identify who are the ones that require a cross monitoring, including admission to ICU. So patients that you think have potential respiratory insufficiency, patients that have got autonomic dysfunction, patients that have got swallowing difficulty, very weak cough reflexes, and patients that have got a rapidly progressive weakness. So these are the features of a patient that will require ICU, because you know that, look, there are potentially, life-threatening complications from the Guillain-Barré syndrome itself. So to do that, sometimes you don't really know how to, classify whether these patients will require ICU or well, they don't. So there is a very good scoring prognostic tool. We call it Iramus GBS respiratory insufficiency score. In short, we call it AGRIS. So this AGRIS actually have three things that you look for. So first features is the days between the onset of weakness to admissions. Whether if the onset of weakness to admissions is within 3 days, you got a higher score. If there's a facial and a bulbar muscle involvement, again, you got a higher score. And if the patient that comes to you with a very weak upper and the lower limb muscle, we call it very low MRC sum score. Okay, means they are very weak, they have a higher score. So if you were to score these three features, all right, and you can give a total score of what called AGRIS score, and based on this score, you will be able to predict how likely is this patient is going to develop respiratory insufficiency within the next 1 week. For example, if you got someone that have got a score of 7, you know that 90% of them is going to require ventilation, because when your score is very high, these are the patients with high risk of developing respiratory insufficiency. Excuse me. Upon admissions, you need to start the patient on treatment. To start patient on treatment, not every GBS patient required treatment. Yeah, some of them with very subtle or mild weakness, you probably just treat them conservatively. They do not require treatment. For those patients that can't walk independently for 10 meters, for those with progressive, rapidly progressing weakness, these are the patients that you might want to consider starting immunomodulator therapy. If the patient has got autonomic dysfunction, bulbar dysfunction, or respiratory insufficiency, yes, treat them. And some of the patients with pure Miller-Fisher syndrome, they only have some ataxia, very mild areflexia, and also ophthalmoplegia. But these are the patients that have very mild disease course, and most of them recover completely within 6 months without needing definite therapy. So your judgment is, somehow important in deciding whether this patient actually needs to be started on IVIG or plasma exchange. In the patients with bigger stuff, brainstem encephalitis, of course, it justifies treatment because these patients, can develop complication very easily because of the somnolence and also the reduce in the conscious level. Yeah, treatment is by either intravenous immunoglobulin, which the best is started within 2 weeks of the disease onset, and if someone that exceeding that period of time, it comes within 4 weeks, you can always put them on the plasma exchange. So the dose of the immunoglobulin is 0.4 gram per kilos of body weight over 5 days, and plasma exchange again is about 200 to 250 mils plasma per kilo of body weight every other day for 5 sessions. So these are non-specific, non-targeted therapy. Basically, you give immunoglobulins to to treat the immune system. You do the plasma exchange to remove all the antibody in the body that can cause the GBS. So these are non-targeted therapy. Basically, it's just it's like you're giving a meronym for infections that you do not know. It's just a broad spectrum kind of therapy. So the plasma exchange, some people say that you give a plasma exchange, then you give IVIG again, but this is not proven to be beneficial than just either one of it alone. And there's insufficient data to say that, look, adding on steroid to the patient with GBS will improve outcome. Okay, so the routine monitoring of the patients after starting on treatment again is the same. You monitor the respiratory function, and you see how much they improve by checking their muscle strength in the arms, the legs, and also in the neck, based on your MRC MRC scores. You check for the functional improvement based on what I call a GBS disability scales. You assess the swallowing, their cough. You assess the autonomic dysfunction, and you provide them with general ICU care until they are being extubated and discharged from ICU. What about outcomes? So after the initial progressive phase of the disease, I show you the time course, right? Most of the patients with GBS will reach plateau, and subsequently, over the next weeks and months, they will recover, even without treatment, right? So up to 80% of the patients with GBS, will be able to walk independently at 6 months after the disease onset. So still about 20 to about 40% of the patients, even if you were to treat them with IVIG and also with plasma exchange, they do not improve. Yeah. So not to say that, after you put them on treatment, they're going to improve. No, still a proportion of the patients that remain disabled, despite giving them treatment. So that's why sometimes can be quite frustrating. Some patient comes to you with GBS, you treat them, but they don't improve. And some of the clinicians actually consider giving them second treatment, a repeated treatment. And again, there's no evidence to suggest that giving them the second IVIG or giving them the second time of plasma exchange is going to improve the outcome. So this is the recent study they look at those patients that have got a poor prognostic score of GBS. If you were to give them 2 courses of IV agent, how they do. In fact, not only you do not see a better outcome, in fact, you see a more side effects from the IVIG itself that can cause even more thrombosis. So these are something that we need to consider, because sometimes previously we used to treat patients with one IVIG, and then after 2 weeks, no improvement, we give another IVIG. In fact, from the study itself, it does show that it causes more harm than doing good. Yeah. Of course, some of the patients improve, but they do not improve very significantly, or they deteriorate again after the initial treatment. So these are the patients that you treat them initially with IVIG, they improve, but subsequently they drop again in terms of their weakness. So these are the patients that we call a treatment-related fluctuation. But because they actually responded to the first treatment, so you can consider giving them the second treatment if you want to repeat the same treatment, because these are the patients that respond, but however, the inflammation of the nerve is still ongoing, despite your treatment effect has already worn off. So these are the patients that you can consider giving them repeated treatment. Yeah, of course, if the patient have got no response initially, or have a poor response to the initial treatment, you don't treat them, because if it doesn't work, it doesn't work. Up to, again, 80% of the patients with GBS will regain the ability to walk, and some of them might develop long-term residual disability and symptoms, for example, neuropathic pain, weakness, and also fatigue. And there was this score that we will score them upon admission, and also at day 7 admission, to predict how likely this patient is going to regain the ability to walk at 6 months. So this is what we call the modified Erasmus GBS outcome score, or what we call EGOS. So if the patients that come in with certain features, for example, if they are less than 40 years old, they have no diarrhea, and if the score are actually the muscle power score are good, okay, they are less likely, they are more likely to be able to walk at 6 months. So of course, if you come as an elderly patient, you have diarrhea, and if you come with a severe weakness on admission and also at day 7, these are the patients that is less likely to walk at 6 months. So based on this score, we will be able to predict upon admission and also day 7 of admission whether this patient will do well in 6 months' time. Okay. So death occur among GBS patients, in about 3 to about 10% of the cases, but this is old figure. We don't see so much of death in the developed countries, and but of course the death rate is still quite high among the developing country. It's mainly because of the cardiovascular, your autonomic dysfunction, and also your respiratory complication. So we know that GBS, even if you don't treat them, they will recover. So why they die is because of the support of the ICU, whether you have enough ventilator, whether you can prevent them from developing complications. Your supportive treatment is very important in determining whether the patient survives. So that's why in a country with less developed healthcare system, so the mortality rate tends to be higher compared to country with a very well health care system. A death of GBS, in a developed country is a big thing, but but up to about 10% of the patients who die is not in a developing country. Unfortunately, these are mainly concerning healthcare services. All right, so you can get recurrent GBS, which is probably up to about 5 to about 7% of the patients. But again, they are rare. You don't really see them that often. Okay, so what does that mean? So patients still die from GBS. We still do not have a specific treatment for GBS itself. And what treatment we have, like IVIG and plasma exchange, are non-specific therapy. And in fact, only 60 to 80% of the patient will eventually recover. So all these features actually tell us that, look, we still have not found the best treatment for Guillain-Barré syndrome. So this is why scientists are constantly, finding ways to treat autoimmune diseases, including Guillain-Barré syndrome. And from my initial slide on pathophysiology, we know that GBS has, some form of complement deposition and also complement activation that subsequently result in the nerve inflammations and the manifestation of the Guillain-Barré syndrome. So if you can stop the complement activation and you can stop the complement deposition on the nerve, theoretically speaking, you can stop the inflammatory process. So I think most of us know that you have a complement cascade that being activated upon infection and also the antibody production, and subsequently you go through your C1, C2, C4, C3, and subsequently your C5 complement activation, and subsequently resulting in what we call a MSC formation, and this will lead to the macrophage that actually invades the nerve and destroy the nerve. But if you can stop the process along the way, theoretically speaking, you will be able to stop the complement activation. You are able to stop the damage. So first is whether you can actually cleave or destroy the ganglioside antibody from binding onto the nerve. So if you can do that, all right, using IgG degrading enzyme, you can probably stop the whole cascade from happening. All right. Second option is you have what we call an anti-complement factor 1, a C1q inhibitor. And if you can stop this process, again, you can stop the complement cascade. And now, the more widely used one are actually a complement factor 5 inhibitor. And again, you can block this one, you can block the process. So eculizumab, which is a complement factor 5 inhibitor, prevent the anti-ganglioside mediated neuropathy in the murine models. Okay, but what about in human? So there are these two large study that not to say large study. There are these two studies that was being performed on a small number of patients, 5 and also 23 patients receiving complement factor 5 inhibitor, which is your eculizumab plus IVIG, and to see whether they have any different in outcome on a patient with GBS. It shows that look, adding eculizumab is safe and well tolerated, and if eculizumab are given together with IVIG, it improves the outcome of the patient's ability to run at 24 weeks. So meaning that you have a better functional recovery with eculizumab plus IVIG. This treatment is well tolerated. Of course, it is can have some serious potential adverse event, which involve some patients developing some form of intracranial abscess, right? And again, if you can have a anti-complement factor 1 C1q antibody that block your C1 complement cascade, you theoretically it will work. So C1q targeted inhibition of the complement pathway prevent injury in the mouse model of a patient with a Guillain-Barré syndrome, Aman from a Guillain-Barré syndrome. But this is at the very early stage of the research. And again, if you can have something to cleave the antibody, which is your anti-ganglioside antibody. So these are the IgG degrading enzyme that's secreted by the Streptococcus pyogenes. And in this study is currently in the phase 2. We are still awaiting response and to see whether this form of treatment actually works. Right. So newer therapies, even newer therapies, is the use of what we call a recombinant antibody that inhibits your FcRn, which is your neonatal Fc receptor. So this neonatal Fc receptor is very important in IgG homeostasis, the immunoglobulin homeostasis. So recombinant antibody itself actually enhances the degradation of the circulating anti-ganglioside antibody. And because you reduce the circulating ganglioside antibody, you prevent the antibody from causing damage to the neuronal injury. Again, this is in the very early stage of studies. And more interestingly, there are something called TAK242, which is actually a very small molecular compound that acts to inhibit what we call a TLR4. So this TLR4 is actually a transmembrane receptor expressed on the immune and the non-immune cells. So if this TLR transmembrane receptor is being blocked, okay, by this TAK242 on a mice model, which is designed to have to develop autoimmune neuropathy within 4 to 6 months, and by blocking this TLR4, it's actually shown that on the mice model you can prevent severe myelin and also axonal loss. Again, this is very early, it's still in the mouse animal models, and I'm not sure whether it will even it's too early to say whether it will actually progress into a human trial. We're just going to touch a little bit on COVID-19 and also COVID vaccine and Guillain-Barré syndrome. So this is the latest review paper that was being published in a Peripheral Nerve Society journal, looking at COVID-19 and also peripheral nervous system, a 2-year review from the pandemic to the vaccine era. So this is the new, this just came out last month. So they gathered all the literature that have been published with regards to COVID-19, COVID vaccine, and also the development of Guillain-Barré syndrome, including Bell's palsy and things like that. So the summary is, of course, there are increasing literature that links COVID-19 to peripheral nervous system diseases. But however, the pathophysiology itself, correlating between this COVID-19 and also the peripheral nerve disorder remains premature. But actually, the COVID virus, similarity of the COVID virus and also the antigen on the peripheral nerve is extremely rare. So you not like your Campylobacter jejuni and also your ganglioside, they are quite similar in terms of the molecular structure. But for COVID and also for the peripheral nerve, is rather not the same. Okay, the molecule and the antigen that they share, the similarity between them are very small. That's why it's very difficult for us to explain, the pathophysiology behind a GBS that is caused by a COVID-19 infection or even the COVID vaccine itself. And so the epidemiological data is very conflicting. You see an increases cases of GBS with COVID in France, but you don't see it in the UK and you don't see it in Singapore. So the data are very patchy and is insufficient at the moment to make any conclusion. Yeah. So with regards to the use of COVID-19 vaccines, you probably have just a higher risk of developing a facial nerve palsy, which is your Bell palsy, which we do see in our routine clinic very often, and also we probably with a GBS probably is just higher risk, but the risk itself is insufficient for us to say that, look, having a COVID vaccine itself, predisposes you significantly into developing Guillain-Barré syndrome. No, so it's still the advice is you still go for the COVID vaccine, although the risk of developing peripheral nerve disorder, autoimmune peripheral nerve disorder is probably just by slightly high, but we do not have a very strong data to support it at this moment, despite 2 years of pandemic so far, right? So to wrap things up, so just a quick conclusion. So GBS can be a complex disorder to diagnose, sometimes because of the heterogeneity in terms of the presentations, and the outcome itself can be quite varied, depends on what kind of treatment the patient receive and where the patient is and what kind of healthcare system that you have. So high clinical suspicion is required to pick up a variant GBS, because this kind of variant can can present as many other different kind of mimics of other diseases. So the current treatment available is non-targeted, but we want potentially more targeted therapy for Guillain-Barré syndrome. And there are ongoing study in improving diagnosis treatments currently, and of course this is very much needed. And, with that, thank you.
Thank you so much, Hugh. It is a very, very comprehensive talk. And I think it is excellent for medical students and even doctors who are actually going for MRCP. And talking about MRCP, actually, Sunway Medical Center is the first private medical center to take PACER for MRCP, right? So we have started last year and then we're going to continue. There is a question by Jack. Okay, is there any data on which COVID vaccine used in Malaysia more likely to cause GBS?
Betty, we were just talking about it.
Yeah, we were just talking about it just now.
Actually, we don't really have any data provided by the ministry, unfortunately. So we can't answer you these questions.
Yes, I think we have to. Okay, for us to have data, we must be more transparent. Yeah. And I think and not only we have to be more transparent, we have to actually be very clinical. We need to be very academic, okay? And data collection actually is not that easy. And a lot of times I think we dismiss a lot of the patients with symptoms, especially if they're just mild kind of
symptoms. Yeah, I just like some of the patients that comes to my clinic, they complain that they have numb hands, numbness in the legs. Somehow some of them are actually GBS. Yeah.
So I want to say this: GBS must be a very scary disease to have for a patient.
Not actually though. Majority of the GBS itself, they are not severe. Majority of the GBS are not severe. Yeah. So
just to imagine
majority of them are being
you can't walk or you can't move and it's progressive, and while you are cognitively functional.
Yeah. But it's something which is treatable, first thing. And second thing is they recover. As long as you can support them well, you have a good supportive system, you got a good rehab system, you can manage all the complications. Majority of them survive. Actually, death of GBS is very rare in Malaysia. It's extremely rare. Yeah.
But what is the usual duration of hospital stay?
Normally they stay about a week or two, basically. Yeah, unless those that with severe complications involving autonomic and also they got respiratory, they need prolonged ventilations, and some of them that do, some of the 20 to 30% that do not respond to treatment. So these are the ones that will require long stays, and in fact they will even be they will even require in-house rehabilitations for months before they actually recover.
Serena asks, is the outcome of GBS related to the speed of treatment? The earlier the treatment is started, the better the recovery.
Yes and no. Yes, in the sense that, let's say if you have someone that comes to you at a very early stage and you have not really, and there's not been a severe nerve damage, and if you can put them on a treatment early, yes, it can. But the thing is, we know when you put them on the IVIG now, you only see the effect one week or 2 weeks later. You don't see the immediate effects of the IVIG. And it's not like, when you put them on the IVIG, the second day, the inflammation all comes down. No, the inflammation was still ongoing until your IVIG takes the full effect. Yeah. So who will develop a more severe disease itself is very difficult for us to predict. But of course, having said that, if you don't treat them, they will be worse now. So if you were to treat them, and it also depends on the speed of how you treat them. But for those patients that has already neurological peripheral nerve damages because of the initial inflammation, sometimes you put them on the plasma exchange, we want a fast effect. Yeah. So we're going to remove the antibody straight from the plasma. And again, this gives you a better kind of like a treatment response comparing to you giving IVIG and then you wait for another 1 or 2 weeks for the response to kick in. So again, that's why my answer is yes and no, because yes, in a fact that in some patients when you give them the IVIG they do improve very quickly, but no in a sense that some of the patients that takes very long to see the IVIG effect, especially because this IVIG is metabolism is not the same in every patient. They are not the same. Some patients are IVIG responder, some are not IVIG responder. Yeah, this a lot to do with the polymorphism of how your IVIG is being metabolized in your body.
Serena says she had Gullain GBS in her 40s with classical presentation and treated with IgG for 5 days. Oh my God. Were you scared? Okay, we wait for her answer. But I want to ask you, is there any role of, let's say, high dose of steroids like dexamethasone? Or
No. Somehow the inflammatory response of Guillain-Barré syndrome, they probably have some effect with steroid, but in terms of the clinical outcome, there's no additional benefit of giving them steroid. They just do not show faster recovery, or they don't show a more respond in terms of the treatment with by adding steroid. It doesn't.
Yeah, I can imagine, Serena, that you must have been very worried. I mean, I cannot imagine, losing motor power, okay, which is progressive, while cognitively I am still very, alert and everything.
Yes, yeah.
Yeah, so I can very imagine. Now, the other thing that I want to say is that it is very rare, right? I mean, to do a study on any mode of treatment is quite difficult. For example, not like if it's a heart attack where every other few minutes you see one.
Yes, it's a rare disease. It's considered a rather rare disease. So that's why to do a large randomized controlled trial on GBS is not easy.
Yes, almost impossible, I would say.
Yeah, but of course, nowadays we have international collaborations, and you have cases. They have studies that is ongoing, looking at thousands of patients with Guillain-Barré syndrome. But again, to test, one new drugs on a Guillain-Barré syndrome on a large scale is not easy, because you probably can get 1,000 heart attack in Malaysia within like a couple of months. But to get 1,000 of a GBS worldwide, it takes years to happen. So it's not so straightforward lah.
And this anti-ganglioside antibody,
yes,
how readily available is this test?
Yes, in Malaysia it's readily available. Yeah, so you can send it to the private lab. We call it Lab Link. Under KPJ. Of course, the result itself need to be interpreted by cautiously by the physician, but it is available. Yeah.
And how long will the result come back?
3 days.
3 days, and how much is it?
It come in the panel, because ganglioside antibody has, they have many different gangliosides, both including the IgM and also IgG. So one panel itself, it costs around 1,000. Yeah.
I see.
Yeah.
Okay. Just to kind of refresh my poor memory, and this transverse myelitis, okay, is it also an autoimmune disease? I've completely forgot.
Yes, yeah. So transverse myelitis manifestation is autoimmune disease, and it is also another interesting field that those in the neurology field actually doing a lot of research, because transverse myelitis in neurology are very often related to either you have multiple sclerosis or you are neuromyelitis optica spectrum disorder, NMOSD.
I see.
So of course it can be idiopathic transverse myelitis, but The autoimmune transverse myelitis nowadays also include, as I mentioned, MS, multiple sclerosis, neuromyelitis, and also the newest one, you call it MOC, anti-MOC antibody. It is myelin oligodendrocyte protein antibody. So these are the newer autoimmune diseases that cause transverse myelitis, and it's very exciting. Again, you know, whenever we have all these autoimmune disease, we talk about new treatment, new diagnostic tools, you know, new antibody. So these are a lot of new things that is happening.
But oh, okay. Liu Lysine said, oh, you are unable to scan the QR code. Okay, if you can't scan the QR code, okay, let me just tell everybody. Please email me. Oh, WhatsApp me lah, easier. WhatsApp me your name, MMC, and IC number and email to 01271233348. Okay, we will have to do it manually. Some people, yeah, some I don't know why still cannot do it. It's also another thing that I just find it very interesting that Zika virus infection increases the risk of Gullain-Barre, but not the dengue. Yeah,
actually dengue does cause Gullain-Barre, but it's much rarer. Yeah, it's very rare compared to other form of viruses. Yeah, but we don't really know why.
okay.
Yeah, but Zika does. Yeah.
I think if there's no more further question, we will stop here. I will stop the share and I will stop the recording.